Hi guys, welcome back. Next up is high altitude pulmonary edema, and in the recent exams they asked what is the type of hypoxia seen in this condition. Options were histotoxic hypoxia, anemic hypoxia, hypoxic hypoxia, and a lot of guys did not even bother to read the fourth option and answered this as hypoxic hypoxia. Now what you have to realize is that hypoxic hypoxia per se is due to intrinsic lung disease. Suppose a person is having interstitial lung disease or emphysema, chronic bronchitis, intrinsic parenchymal lung diseases. That is when we say person is having hypoxic hypoxia. The type of hypoxia that is seen here is technically called as hypobaric hypoxia, and the logic or the rationale is very simple and straightforward that the higher you go up in the atmosphere thins out and the concentration of oxygen tends to decrease. So I would say that this is more of a physics-based question, that the type of hypoxia encountered in high altitude pulmonary edema is hypobaric hypoxia. In fact, at the highest mountain in the world, you see when these guys go for climbing at Mount Everest, they would be carrying a backpack that would be having a sleeping tent and the gear and the climbing gear, and apart from that they'll be also carrying a oxygen cylinder as well, because high up there the inspiratory partial pressure of oxygen at Mount Everest is a mere 43 millimeters of mercury. Like while you and me are sitting comfortably in this room, the IPO2 for us is about 100 millimeters of mercury, whereas at a height of about 29,000 feet, that would be about 8,800 meters, that is the highest mountain in the world, the inspiratory PO2 is only 43 millimeters of mercury, which is why I said they would be carrying in their backpack an oxygen cylinder as well to aid in climbing. So let us now focus on the pathophysiology of the disease. In fact, the topic that we're studying here, the broad term to describe that would be called as acute mountain sickness. Some people might be having only a headache, or they might be having nausea, vomiting, bloating, a bit of disturbed sleep, fatigue. But some patients can go and deteriorate really fast and can develop high altitude pulmonary edema. This would be a non-cardiogenic pulmonary edema, and some people can even develop disorientation and can develop high altitude cerebral edema. In fact, if you go to base hospital, anywhere, military hospital, you might come across young officers who were posted at the highest battlefield in the world, that is Siachen Glacier, and they suffered from high altitude cerebral edema, because of which they might remain in coma for a variable period of duration and sometimes may never come out of it as well. So let's look at what is going wrong high up in the mountains. How is mountain, the adverse environment, killing a person? Well, the first thing would be that because of the hypoxia component, there would be a dilatation of the cerebral blood vessels. When the cerebral blood vessels will dilate, they will cause stretching of the dura mater, and dura mater is the pain sensitive structure in the brain. Even from your central nervous system discussion, you're aware that the pain sensitive structure in the brain is dura mater, and due to cerebral vasodilation, the stretching of the dura mater will bring in the sensation of headache. And if you've really been to a high altitude area like Hardungla, the highest motorable road in the world at 16,000 feet, then you would be better relating to what I mean here. That's a splitting headache that does not go away with routine painkillers. Now, even more dangerous is the hypoxia component that can cause a pulmonary vasoconstriction. And you will notice that hypoxia will cause dilation of all blood vessels in the body except pulmonary circulation, which exhibits a vasoconstriction. The reason why it's different, the rationale behind it is simply that pulmonary vessels would be carrying, pulmonary artery per se would be carrying carbon dioxide. So though it's an artery, it's carrying carbon dioxide. So it behaves a little different from what the other blood vessels in the body would be doing. And therefore, the textbook says that all patients who are deteriorating start developing patchy pulmonary vasoconstriction. Now, the importance of knowing this is that whenever there is vasoconstriction anywhere in the body, then proximal to wherever there is a vasoconstriction, the hydrostatic pressure will begin to rise. And therefore, due to the increase of this hydrostatic pressure, I can say that proximal to wherever there is going to be vasoconstriction, there would be overperfusion of some areas of the brain. See, what I'm saying here is a ventilation perfusion mismatch. They've documented in clinical studies that these patients develop patchy. Some areas of the lung would be having vasoconstriction. And whenever there is a vasoconstriction, proximal to that, there would be increased pressure. That is overperfusion of some areas of the lung might be present. And that's a problematic issue, because if you have overperfusion of any area, then there is going to be shearing stress on the blood vessels. When I say overperfusion, more blood supply in that area, there would be stretching of blood vessels. There would be increased shearing force on the pulmonary pulmonary capillaries, and therefore he says that there can be a capillary stress failure. Let me explain this once again. What I mean by the word capillary stress failure is that let's imagine this circle to be the alveoli, and then surrounding this would be multiple blood vessels, which are the pulmonary capillaries. And what is happening in this condition is that due to vasoconstriction in some areas, the proximal area pressure is rising. So now what I by plus sign imply that the pressure in these pulmonary capillaries is elevated. The reason why this pressure is elevated is not because of heart failure, because this condition is not going to involve the heart. It is simply a problem of the lung, and which is the reason why the type of pulmonary edema that is present here is called as non-cardiogenic pulmonary edema. Due to the increased pressure in these capillaries, there is a stress failure. I mean, the endothelial cells become leaky. And now what I'm trying to show here is that there is a transudation of fluid, there is extravasation of fluid outside from the pulmonary capillaries into the alveoli. And therefore, these patients will start developing wet lungs. And that is why we get pulmonary edema. That is why shortness of breath will start occurring. That is why crepitations in bilateral lung fields will start developing in these patients. What you can see here is capillary stress failure. In fact, I can explain this once again in a slightly different way, because he says that because this person will also be doing exercise, because he's carrying a backpack that will be having all the mountaineering gear, will be having his sleeping tent, cooking utensils, food, etc. So he's doing physical stress also. At the same time, there is extreme harsh, cold mountain air, which triggers a bronchospasm as well. So due to combination of hypoxia plus exercise plus cold, there is excessive sympathomimetic stimulation in the body of this person. Because of the sympathomimetic stimulation, he says there can be a development of pulmonary vasoconstriction. Because of this pulmonary vasoconstriction, again, what's going to happen is that the pressure in the pulmonary capillaries will begin to rise. So I gave you two reasons why the pressure in the pulmonary capillaries is rising. One is simple pulmonary vasoconstriction due to sympathomimetic stimulation. Second is this ventilation perfusion mismatch, whereas some areas exhibit a vasoconstriction, some areas rather show a overperfusion, and this contributes to capillary stress failure. Ultimately, what I'm trying to explain is that there is fluid leaking out of these blood vessels into the alveoli, which results in wet alveoli, which is why pulmonary edema will develop. And overall, I can say the type of pulmonary edema that we encounter in this condition is same as what we get in ARDS, that's acute respiratory distress syndrome. The type of pulmonary edema that is seen here is called as non-cardiogenic pulmonary edema. See, if it was cardiogenic pulmonary edema, then left atrial pressure would have been elevated. I mean, left ventricular failure always causes a cardiogenic pulmonary edema, as you know that from the cardiology discussion. So in this condition, if I'm going to do an echocardiography and if I'm going to evaluate the pressure status in the left atria pressure is going to be perfectly normal. So there are two examples of non-cardiogenic pulmonary edema that you guys have to know for your exam. That's going to be ARDS, also called as acute lung injury, shock lung in pathology, and today we are studying high altitude pulmonary edema, which is again an example of non-cardiogenic pulmonary edema. Let us now focus on the third reason why these patients would be having a pulmonary edema component. That's because, see, the endothelial cells which are present, endothelial cells would be lining the pulmonary capillaries. Endothelial cells are highly vulnerable to hypoxia. Now, endothelial cells, they're responsible for nitric oxide production, and nitric oxide basically causes vasodilation. If endothelial cells are damaged, and the reason for this damage is the vulnerability of these cells due to hypoxia, then I can say that these cells will again become leaky, and therefore fluid will start leaking. There would be extravasation of fluid into the alveoli from the pulmonary capillary vessels, and therefore non-cardiogenic pulmonary edema will occur. There would be less nitric oxide being produced. And the reason why I'm explaining point number 3 specifically is that though 1 and 2 are sufficient for understanding what's going to happen, it's going to be tremendous splitting headache, there's going to be breathing difficulty. That's the initial presentation of these patients, along with vomiting, nausea, bloating. But there is less nitric oxide production as well, and this all explains the fact that why in the later part of this discussion you will see me or you will hear me saying that even tadalafil, that's a phosphodiesterase 5 inhibitor, is useful for management of these patients. So the rationale behind usage of phosphodiesterase 5 inhibitors is that they are going to enhance this nitric oxide production, in a sense that in this condition the production is rather lesser because the endothelial cells are getting destroyed primarily because of hypoxia. The fourth problem, which will explain the manifestations of this chap and will also explain why acetazolamide will be useful, is that we come across Cheyne-Stokes breathing in these patients. Now that looks very surprising because traditionally we read about Cheyne-Stokes breathing with the raise ICP, we read with Cheyne-Stokes breathing with respect to congestive heart failure. So now you are aware of three reasons why Cheyne-Stokes breathing can be present. It can be raised ICP, congestive heart failure, and mountain sickness. These are three reasons for Cheyne-Stokes breathing. And what happens in Cheyne-Stokes breathing is periodic breathing. What I imply by periodic breathing would be periods of hyperventilation followed by hypoventilation. Because of hypoxia, the person will hyperventilate. And when hyperventilation will occur in excess of normal, then the body will try to correct this by causing a hypoventilation. What you get in these patients is periods of hyperventilation followed by periods of hypoventilation. What is basically happening is that the body is not able to adjust, or the respiratory center is not able to adjust to this sudden onset hypoxia. I mean, this guy, he has lived in the plains, like you and me live on plains, and we catch a flight, we get to Leh and Ladakh, and on the first day itself we go for hiking. Because we are not acclimatized to that low oxygen tension in the atmosphere, our respiratory center will not be able to adapt to that sudden decrease of oxygen in our body. So to compensate for that low oxygen in the body, what's going to happen is that we will tend to hyperventilate, and the body will tend to do excess of that. And what happens is that there would be hyperventilation, then body will try to correct that by causing a corresponding hypoventilation. And this is especially visible when the person is sleeping. I mean, if we are going to check the SpO2 of a person who's high up in the mountain, the SpO2 will not remain constant. It will keep on fluctuating. In those periods when the person would be having hypoventilation, the SpO2 of this person will begin to fall. Then when person will hyperventilate, it will tend to come back to normal. But because of this variable SpO2 at night, when the person is sleeping and he's not realizing that he's having this periodic breathing, though a person who's watching him might be able to observe it, especially if he's a doctor. But this variable SpO2 will explain again why the person will wake up with headache, or he will say that I did not wake up fresh high up in the mountain. So the reason why, if you ever been to Leh and Ladakh, and the reason why you have a disturbed sleep is not that it is biting cold there. Obviously that will contribute. If you're not sleeping in your bed anyway, sleep can be disturbed, but the fluctuations in oxygen concentration contribute to disturbed sleep, which means that there would be excessive amount of fatigue present. And that's what even this guy might be, he might be a gym rat, I can say. I mean, this guy is very fit. He regularly goes to a gym and he considers himself to be super strong, because high altitude pulmonary edema can affect just about anybody. So though this guy said he's a gym rat, he lives in a gym all the time, he does extensive workout, but he can fall sick, he will feel excessively fatigued, primarily due to the fluctuations in the oxygen concentration, primarily because of hypoxia. So there would be disturbed sleep, there would be excessive fatigue and shortness of breath experienced by these patients. And over and above this, when you tend to hyperventilate, the air will go in the esophagus, and that's when via the esophagus into the stomach. So you will also notice that people who go to high altitude also complain of lot of flatulence. They also complain of excessive amount of flatus, and what we usually find is high up the chances of hemorrhoidal bleeding also tends to increase. Though there can be multiple reasons for that. When you're climbing, you may not be drinking sufficient amount of water, that can cause constipation, that can worsen hemorrhoids. But overall, I can say hemorrhoidal bleeding, I'm not saying that he will develop new onset hemorrhoids. What I'm trying to say is that if a person is already having hemorrhoids, his hemorrhoidal bleeding chances of hemorrhoidal bleeding tends to increase high up in the mountain. And over and above this, you can also, I have tried to give pathophysiology regarding these very non-specific looking symptoms that are also encountered with respect to acute mountain sickness. And the primary problem this guy is anyway going to be shortness of breath, the decrease in oxygen saturation, and that would explain why the pulmonary edema component will occur, because hypoxia affects endothelial cells. It damages endothelial cells, they can't produce nitric oxide. And the endothelial cells per se are also affected by this ventilation perfusion mismatch that I was explaining to you. So there is, I would say, extravasation of fluid into the alveoli. There's wet alveoli, that's why bilateral clefts in these patients can be auscultated. So by this time, I'm very sure you'd be wondering, sir, I was planning to go on a holiday to Leh Ladakh, and after listening to you, I think I won't be able to go. No, you'll be able to go, but you need to take a bit of prevention. And what I mean by prevention is, the best way for prevention is gradual ascent. You will see that army guys, whenever they're going up for a high altitude posting, no, the convoy will go up slowly. They have flights also, they can take a plane and they can land their soldiers at the highest battlefield. But no, they'll not use, it's not that they don't have facility. Even an officer, though he has a facility of taking a plane, they might be going up using a convoy, which will be going up the mountain rate slowly. And the usual guidelines are that a person should be climbing about 300 meters every day. 300 meters would be approximately 1000 feet every day. So from, like, let me say 10,000 feet to 11,000 feet. So there's gonna set up a camp. They, when they go from 10,000 to 11,000, 11,000, 12,000, they will go up 1000 feet, then they'll come down by a few hundred feet and they'll set up a base camp at that area. And then next day again they will do climbing. So the best way to prevent acute mountain sickness, if you are like a doctor in Army Medical Corps, then how would you be telling your commanding officer that what is the best way to prevent mountain sickness in the troops, in the entire battalion? That would be a gradual ascent, because gradual ascent causes acclimatization. If you go up slowly up the mountain, your body gets gradually used up to the low oxygen concentration, and this would be the best way for prevention of acute mountain sickness. But alone gradual ascent, it may not be also practically possible, and at the same time may not alone be sufficient. So we also need to use a drug, and that's why they will love to ask you regarding acetazolamide. And acetazolamide is a carbonic anhydrase inhibitor. Now, how this carbonic anhydrase inhibitor will work is, one of the mechanisms of action of this carbonic anhydrase inhibitor is that it causes bicarbonaturia. It causes loss of bicarbonate in the urine of a person. If you lose bicarbonate, I can put that as a question to you. If you lose bicarbonate from the body, you're losing alkali from the body, so what will you develop? Metabolic acidosis. And because of this metabolic acidosis, the protons which are now being created, metabolic acidosis is a condition which is an acidic pH. The acidic pH will then stimulate the respiratory center and will cause hyperventilation. And that is good, because if I cause hyperventilation, I will be able to reduce the hypoxia in the body. Especially it is recommended that people who are going up high up in the mountain, if they've had an event like this earlier, or they are predisposed to chances of development of mountain sickness, or I can say in any young guy who's not acclimatized and is planning to go to Leh and Ladakh on a holiday subsequently, then acetazolamide should be specifically taken before bedtime. It will cause hyperventilation and will reduce the hypoxia at night. And because of reduction of hypoxia at night, all these symptoms that I've described will also be lesser, and the chances of damage to the pulmonary endothelium will also be lesser, which is why the chances of even high altitude pulmonary edema will reduce. So if he says what is best for prevention of acute mountain sickness, first answer is gradual ascent, and along with that, the drug support that we use is acetazolamide. And yep, he can put up a pharmacology based question as well, because acetazolamide would be having in the side chain of acetazolamide, a sulfa chain is present, and some people have allergy to sulfa drugs. So if he specifically mentions that a person is allergic to sulfa drugs, then you cannot give acetazolamide. If you read the pharmacology of acetazolamide in one of the side chains would be having a sulfa chain present. And if somebody is allergic to sulfa drugs, then there could be an allergic reaction. I don't want to take up a chance. So I can also be using an alternative drug, that is dexamethasone. I would like to reiterate that statement, that first answer will always be acetazolamide. And when are you going to be prescribing dexamethasone? I said if there is a documented history, if the person himself is telling you that he has a sulfur drug allergy, or in the medical form of the patient it is mentioned that he has an allergy to a particular drug, that sulfur drugs per se, that's antibiotics, right? So that same sulfur drug is what I'm talking about, sulfur drug allergy present, then we can be using Dexona, that is dexamethasone as well. The main mechanism of action of acetazolamide is carbonic anhydrase inhibition, bicarbonaturia, triggering metabolic acidosis. And you are aware that even in diabetic ketoacidosis, no, there is small breathing. So the logic is the protons stimulate a respiratory center, and this is even taught in physiology, that acidic pH of the blood triggers respiratory center. There is a hyperventilation, and it is good that my patient is hyperventilating, because I want to reduce the amount of hypoxia in the body. However, sometimes people, in spite of this, might develop mountain sickness. So he might mention mild versus moderate acute mountain sickness. Now, for mild and moderate, well, these are subjective terminologies. There is no well-defined criteria that, okay, vomiting more than this much, headache more than this much, that we'll call it as moderate, and less than this much, we'll call it as mild. So he says these are very subjective terminologies and depends on the assessment of a doctor. But in a case of mild acute mountain sickness, what is the first thing to be done? We will tell them that you have to discontinue, stop climbing. The first and the foremost thing is that you have to discontinue your ascent. And the second advice of ours would be that you need to go down. Both advices obviously have to be followed together. No more climbing. You have to go down. So he can ask you, sir, the company officer can ask you, okay, this soldier, how low should I send him? Should I send him back to Delhi? Should I send him back to Chandigarh? So I'll tell him, no, this, you need to send him immediately to below the area where the symptoms were first reported. Like for example, I said symptoms developed at 5,000 meters. So, like the troops are climbing to a higher altitude. Maybe they are on a mission. They are on a recce, and if the soldier became sick at 5,500 meters, then and symptoms started developing at around about 5,000 meters. That's about substantial amount of height. Then we would like a immediate descent at this particular point of time, not to immediately to Delhi, and that would not be practical. Also, bringing a soldier down immediately, the logistics involved are tremendous. So our immediate objective would be a immediate descent to below the level where the symptoms, when the soldier started, Jawan, when he said no कि मुझे ये problem हो रहा है, so immediate descent to below the level where the symptoms were first reported by this young soldier. And apart from this, obviously we need to give acetazolamide. So maybe acetazolamide was being given already, it will continue. And what we need to do is that deployment of this particular guy will be cancelled. He'll be sent down so that he can recover, and then we can subsequently, after a few days, we can try to get this guy back up also. If he's having some cardiovascular disease, if he has already served a posting there, then it is up to the commanding officer to decide. But as your doctor, as a role, your role as a doctor would be to send this guy down and continue with acetazolamide. But if the symptoms are much more severe, then what are you gonna do? Then obviously the descent part is anyway there. We will have to tell them to send this guy down and go down to that particular level at which the symptoms were first reported. But over and above this, he also recommends the use of low flow oxygen at this point of time. If you ever been to Khardungla, the highest motorable road in the world, there's a selfie point, and they don't let you stand there for more than 15 minutes. People, they are busy and taking those Instagram selfies, and that army guy will literally be, chap will be carrying a stick, and he'll be literally, kicking people and saying, get down and go back. Because people don't understand, if you stay at that 16,000 feet for a too longer duration, that's gonna trigger these manifestations of high altitude pulmonary edema, and people tend to become sick as well. So at that point of time, the army chap might be harsh. The army chap posted at that area might be harsh with people as well, and people feel bad about it. But then ultimately, when the people become sick, then it's only the army people who will be rescuing them. So low flow oxygen is recommended at this point of time. Along with this, he says that now, along with acetazolamide, you can add dexamethasone. So earlier I was saying, I was describing terms like either acetazolamide or dexamethasone. I was saying that use dexamethasone if there is an allergy to acetazolamide, or there's a documented sulfur drug allergy. But now he says that you can be using combination of the two. So the message from the exam perspective is prevention answer is acetazolamide, mild acute mountain sickness answer is also acetazolamide. If he says moderate, then it would be acetazolamide in combination with dexamethasone, and along with that low flow oxygen would be required. And then you can see this bag. The common name for this bag would be Gamo bag, but technically in the exam, he's not going to use the word Gamo bag. This Gamo bag is a portable altitude chamber. This is operated with help of a foot pump. It basically, you can put the guy inside it. Like even in this small diagram, you can see face of a person inside. So what this portable altitude bag is doing is, it is doing a simulated descent. Like if you put an individual at 5,000 feet inside this bag, then the moment it goes inside this bag and you pump the bag and inflate it to a particular pressure which is recommended by the manufacturer, altitude of the person would be akin to somebody at 2,500 feet, almost 50% of what the original was. I repeat that again. I said this bag, which is also called as Gamo bag, is a portable device. It's a portable altitude chamber, And if you put somebody inside this chamber, the foot operated pump will be used to generate a higher atmospheric pressure, and it will simulate a descent. Like if somebody is at 5,000 feet and is having symptoms, the helicopter evacuation may not be logistically possible. Everywhere a helicopter cannot land. And therefore, what you can put the soldier in this bag, and this would cause the height of this person. If he's inside this bag, the height at which he's gonna be, he's still at 5,000 feet, but it will simulate a descent, and the height at this guy, the height at which now this guy when he's inside the bag would be 2,500 meters only. So this is what is called as hyperbaric therapy. And I don't want you to mix this up with hyperbaric oxygen therapy, because hyperbaric oxygen therapy is what I've described with gas gangrene. So be careful whether he's asking about HBOT, that is hyperbaric oxygen therapy, versus hyperbaric therapy. The meaning of the word hyperbaric therapy is simulated descent. The person is put in this bag, and whichever height he will be. If he's at 6,000 meter, then the simulated descent would be of 3,000 meters. That's the pressure inside the bag is almost gonna create a simulated descent of almost 50% of whatever height he was above the sea level. Let us now focus on what are you gonna do if you are handling a person with high altitude cerebral edema or high altitude pulmonary edema. Your answer would be immediate descent. In fact, here you will be using the word evacuation. The guy would not be in a position to be carried down. So what we need is a helicopter evacuation, ideally in these circumstances, or a vehicle-based transport if it is feasible. High up in the mountains in Siachen, there would obviously be no roads there. So it would be helicopter evacuation in those circumstances. And meanwhile, while you are waiting, because you see helicopters, like we don't have all-weather helicopters. No, if the weather is bad, the helicopter cannot land. In those circumstances, or maybe due to enemy fire, the helicopter cannot land. So meanwhile, waiting for evacuation, the soldier can be placed in what I explained earlier, a portable altitude chamber or a gamma bag, which is hyperbaric therapy, and this would cause a simulated descent. Over and above this, because there is a cerebral edema component present, so he says two things that must be done. One is obviously administration of oxygen, because we want to improve the oxygen delivery to the brain. So the oxygen delivery would be at about 2 to 4 liters per minute, and the main drug that would be used in this case would be dexamethasone. Yes, for high altitude cerebral edema, do not answer acetazolamide, because we are having vasogenic cerebral edema. I have talked about vasogenic cerebral edema, neurocysticercosis, tubercular meningitis as well. So you are very well familiar about the concept of cerebral edema. We have cytotoxic cerebral edema, which is managed with mannitol, and vasogenic cerebral edema, which is managed with dexamethasone. So the main treatment for high altitude cerebral edema would be Dexona. Obviously, it can be given intravenously, it can be given intramuscularly. If it allows, if he is not having severe vomiting, or if he can, then we can give it orally as well. So depending upon whatever feasibility, we are gonna deploy this. And for high altitude pulmonary edema, he says we need to improve the oxygen flow slightly more, because there's a pulmonary edema component. So the flow of oxygen in this case would be about 4 to 6 liters per minute. And along with that, the main drug that would be used in this case is nifedipine. Now, what is the point of using nifedipine? The concept behind nifedipine extended release preparation is that it's going to cause a vasodilation. And remember, I told you right in the beginning, there's a pulmonary vasoconstriction, there is a pulmonary venoconstriction happening. So I want to neutralize that vasoconstriction, venoconstriction, which is causing that hydraulic stress, the shearing stress on the blood vessels, which was causing extravasation of fluid out of the blood vessels into the alveoli, contributing to non-cardiogenic pulmonary edema. So the main aspects in the exam would be, they are going to ask you prevention, they can ask you management of mild AMS, that is acetazolamide. For moderate, it would be answered as acetazolamide and or Dexona. Obviously, hyperbaric therapy makes an entry only for moderate AMS, not for mild acute mountain sickness. And then for HACE and HAPE, which are medical emergencies, immediate evacuation of the soldier is recommended. Most of the time, he's going to describe like this: soldier posted at high altitude exhibits disorientation. He starts developing hallucinations. He starts talking to himself. And that is when, you as a doctor in the Army Medical Corps were called to take care of him. So you'll provide him with oxygen, give him with dexamethasone, or use nifedipine. And the reason for use of the nifedipine, I'll repeat again, is to neutralize the pulmonary extreme vasoconstriction, which is causing the fluid to leak out of the pulmonary capillaries into the alveoli. Let's focus on now some other approaches which are also used for management of this entire spectrum of mountain sickness. One is use of inhaled salmeterol. Now it makes sense because we are giving a beta 2 agonist, so it will cause a bronchodilation, it will cause a improved delivery of oxygen because cold mountain air causes a vasoconstriction. But there's a second reason why salmeterol is also used, and he says that one of the important reasons why salmeterol is used is not because of the bronchodilation part, but primarily because though bronchodilation is obviously there because cold mountain air causes bronchospasm, but he says that it has been documented in studies that beta 2 agonist will also cause clearance of sodium and water from the alveoli. You see, there is water inside the alveoli, there are wet alveoli present, so clearance of salt and water from the alveoli, that is the fluid, will move outwards, and that will cause the alveoli to relatively dry out, and that would be beneficial. Though in clinical studies inhaled salmeterol, there is no, he says that at high altitude sufficient amount of studies have not been done. So at the moment this is not mentioned in the table for management of high altitude pulmonary edema or cerebral edema. He says you can use it. The textbook statement is there is no sufficient evidence of routine usage or no sufficient evidence for prescription to be given on a regular basis, which is why these are like additional supports which can be used. Then again for phosphodiesterase inhibitors, like I mentioned about tadalafil, the logic was nitric oxide production is being reduced, so I just want to upgrade the local nitric oxide levels. So again for phosphodiesterase inhibitors, they're clinically used. They're clinically used, but only certain case-based reports are there with respect to the benefit of this drug, but there is no randomized controlled trials. You see, for any drug to be recommended in the final algorithm, there has to be peer-reviewed randomized controlled trials. So those peer-reviewed randomized controlled trials are not available for both of these drugs, which is why in the current edition of Harrison, he says that they may be used but are not routinely recommended. In the exam, this is what you need to answer, the data that I've explained on the previous two slides. This is adjunctive therapy. And then what I'm saying, especially if you're a doctor in Army Medical Course, you will raise an eyebrow when I'm saying this. He says that if you want to prevent high altitude pulmonary edema in those who have to extend rapidly, let me say you have to send up a unit to the forward post on an emergency basis. And these guys are rookies. They are recruited freshly into the army and they're not acclimatized for high altitude. Suppose there's an emergency mission, like the enemy is trying to take over the forward post, and you are the company officer has asked you to select a couple of guys. I mean, the couple of guys are volunteer to go on a mission, but they are like first time posted at that high altitude, and they are like not very well adapted or acclimatized. So before you send them, and the company commander is asking you that, okay, you are the doctor, can you advise me what can be done so that these guys can go up to there and can handle and can secure the post and keep the post there. So he says that you can be using nifedipine in a sustained release preparation for especially those cases where there is need to prevent high altitude pulmonary edema, in those where there's a need to extend rapidly. I've given a reference of Harrison page number also. I know that if you are in the Army Medical Corps and you're listening to this, you would say, sir, I mean, is this really practical? I mean, you're telling us that should we be giving it? But yes, guys, this is given in Harrison. He has mentioned this line. You can check it out on this page number. He says that you can be giving it in those situations where it's like you have to go up there, maybe to rescue somebody. You have to go up there to secure a forward post because country comes first, as is the norm. I mean, that's where he says that in those cases where the person needs to extend rapidly, nifedipine can be given for prevention of high altitude pulmonary edema. Please, if you are a doctor and you're planning to go to high altitude, this is not the way to go about it. This is only in exceptional circumstances that he has described. So for these 3 points, I'm going to explain that once again. Point number 1 and 2, what he says classically is that routine usage is not recommended. He says case reports are there, but we need, he says we need peer-reviewed randomized controlled trials until they become available, maybe in the subsequent edition of the textbook. Till that, he says you can use it, but it's up to your as a discretion, but otherwise routine guidelines don't mention it. And for the last one, however, he has mentioned that prophylactic use is there even for nifedipine. So at this point, I know at your mind, your question would be, sir, patient ko kya hoga after all? So let's look at what's going to happen with our case. This is a young guy. I mean, mostly young people will be going to high altitude only. It is day 2 or day 4 of ascent. He has already climbed a particular area. I mean, high altitude is usually described at a technical definition of high altitude would be arrival at a height of equivalent to or more than about 2000 to 25. It's a variable range, but he says that at 2000 to 2500 meter, 2000 meter to 2500 meters, that is when usually symptoms will appear. So this guy on day 2 and day 4 of arrival at this particular height will start complaining of excessive amount of fatigue. He will not be able to even get out of the bed. He will complain of shortness of breath on even going to the bathroom. And though this guy, I said, was a gym rat, he was like regularly, he was very regular in his workout, has big muscles, but this guy will not be able to forget about carrying a backpack. He says that I just can't even go about, like he's staying in a hotel. So he says that even if I have to go for the morning breakfast in the hotel lobby, then I am feeling extremely breathless that point of time. So that's what I mean by the word decrease in exercise tolerance from a guy who used to do bench presses or twice his body weight. Even going to the lobby of the hotel to eat breakfast is making him breathless. The second symptom that can come and can be fairly debilitating is non-productive cough. Again, if you have been to high altitude places like Leh or Ladakh, you'll understand what I really mean. And this non-productive cough can be so debilitating sometimes because cold air causes anyway bronchospasm. The cold air can cause bronchospasm, contribute to non-productive cough, which can be so debilitating that it can even cause rib fracture. I mean, you cough so much that it can even contribute to a rib fracture, and this has been documented usually to be present at heights of about 5,000 meters or higher. So at about 15,000 meters and 16,000 feet is about Khardumla, the highest motorable road in the world, where people take a bike from Ladakh and they go up. So that's where non-productive cough would hit in. At this point of time, the person can also have bluishness of the lips. There would be cyanosis coming up, and on auscultation in these patients, bilateral crepitations would also be coming up. Subsequently, when you take the history from the person, he will talk about bloating, he will talk about flatulence. The reason I explained, because when he was sleeping at night, his body was trying to correct the hypoxia by hyperventilation, and too much of hyperventilation means that too much of air is going in. So sometimes when you hyperventilate due to anxiety also, you tend to get flatulence. The same thing is happening here. Bloating and flatulence can be experienced. Along with that, some people could be having excessive amount of flatus passage, and that excessive flatus is again explained by the increased amount of air in the intestine. Chances of bleeding from the hemorrhoids can increase, and generally I can say no need to note down what I say next. If at this high altitude somebody is having a diarrhea, then you must take into consideration possible of Camper's diarrhea. You are aware that at high altitude maybe access to potable water may not be there, and access to water for hand washing may not be there. So person might be eating without washing hands, and that is where giardiasis can come in. So especially the question that can come on this, I think, is taught in microbiology also. We use the term Camper's diarrhea. The term Camper's diarrhea imply giardiasis in an individual, for which specific treatment would be in the form of metronidazole. So these are the usual symptoms that we will see. Let's look at the examination findings. The examination findings would be in the form of bilateral crackles. They usually start in the middle part of the chest. I mean, the middle lobes are initially involved. Right middle lobe and the right lower lobe are the ones which are usually involved, and then it will spread to involving both the lungs. The respiratory rate would be substantially increased. There would be tachypnea, there would be tachycardia. All manifestations of hypoxia and altered mentation will start occurring in these patients as well. This altered mentation is telling us that the person is now, there is a disorientation occurring. So this tells us that the person is also going into development of high altitude cerebral edema. When I'll be doing a workup of these patients subsequently, though at the mountain side, this is what I'm going to find out. But if I'm going to check out the SpO2 of these patients, the SpO2 of this person will always be lesser. Do remember, sometimes they can be concomitant frostbite as well. In a setting of frostbite, well, the SpO2 readings are not very accurate because of the exaggerated vasoconstriction that might be occurring in the tips of fingers. At this point of time, if ABG is done, though this is obviously a flight of fancy because facilities like that will not be available at that high altitude area, but because of the hyperventilation component, still for the MCQ sake, I've taken care of this in the ABG section as well. Carbon dioxide washout. Carbon dioxide forms carbonic acid. If carbon dioxide is less in the body, less carbonic acid. If less carbonic acid, respiratory alkalosis. Suppose the condition has more carbon dioxide production, like status asthmaticus. So if carbon dioxide is more in the body, in status asthmaticus, more carbonic acid, respiratory acidosis, and here because there's a carbon dioxide wash out occurring from the body, that is why I've said respiratory alkalosis would be present. If I do echocardiography, there would be pulmonary artery hypertension. Pulmonary artery hypertension will cause evidence of right ventricular strain. Sometimes right ventricular strain can be picked up even on the basis of ECG. And when I evaluate the left atria of this person, the left atrial pressure will always be normal. As I explained to you, that when left atrial pressure is elevated, that means person is having cardiogenic pulmonary edema, because somebody who's going to Kailash Mansarovar Yatra, If he is a known case of heart disease and he goes for Kailash Mansarovar Yatra, he can develop cardiogenic pulmonary edema as well. And there have been instances when people who were having heart disease, ischemic heart disease, went for Kailash Mansarovar and died. There they died not because of non-cardiogenic pulmonary edema, they died because of cardiogenic pulmonary edema. They should not have been there. Kailash Mansarovar Yatra is really, really difficult, and it's not for those people who are having blockages in their coronary artery. Next up is chronic mountain sickness. This is for residents of Tibet and then also Andes Mountains. You're aware that the Andes Mountains are in South America. That's close to Argentina and Chile. So people who are living at this high altitude, because they're going to be subjected to long-term hypoxia, therefore long-standing hypoxia will contribute to increased erythropoietin production from their kidneys, and therefore these people would be having secondary polycythemia and erythrocytosis. The problem with this erythrocytosis would be that there would be sluggish circulation in the lungs. I repeat that again. You are aware of polycythemia vera. That's a tumor, that's a myeloproliferative disorder related to normoblasts. But then you read about secondary polycythemia. You read about secondary polycythemia and chronic bronchitis, COPD patients, and then you read about secondary polycythemia and tetralogy of Fallot. But today we're talking about chronic mountain sickness, guys, which is also taught in physiology as Monge's disease. Most of the time, I don't think so that he'll write Monge's disease in MCQs, because people are able to then crack the questions. We'll just say chronic mountain sickness, because prior to this, acute mountain sickness is what we discussed. In chronic mountain sickness, the problem is hypoxia causing excess production of erythropoietin from the kidneys. It's secondary polycythemia causing erythrocytosis. Apart from this, as I've explained, hypoxia will cause pulmonary artery hypertension, and due to pulmonary artery hypertension, ultimately, the main manifestation of chronic mountain sickness would be right ventricular failure. That's cor pulmonale. So one of the causes of death in chronic mountain sickness is heart failure, and that's because of the cor pulmonale component. As you know, that cor pulmonale basically means right ventricular failure due to non-cardiogenic causes. We have discussed in cardiology section also a very funny MCQ that the leading cause of right ventricular failure is left ventricular failure, but that's going to be cardiogenic, na? Here we're talking about right ventricular failure due to non-cardiogenic cause, and the reason for this is a combination of erythrocytosis and pulmonary artery hypertension, which ultimately contributes to right ventricular failure and leads to death. So what we can do about these patients? What we can do is that if we remove blood from the body of these patients, if I deliberately, traditionally we give blood to patients as doctors, no, here we are removing blood from the body of a person, and that will bring down the hemoglobin, that will bring down the RBC count, because RBC count is tremendously increased. It's causing a sluggish circulation of the lungs. So if I'm going to bring down the hemoglobin counts and the RBC counts, it's going to be beneficial. Apart from this, even acetazolamide has been shown to beneficial for management of Monge's disease. So acetazolamide came up total of 4 times: prevention of acute mountain sickness, mild acute mountain sickness, moderate acute mountain sickness, where it was used in combination with dexamethasone, and now it is being discussed even for those cases where a person would be having chronic mountain sickness. The alternative name for it, even read by you in physiology, is Monge's disease. Next up, I'm going to talk about environmental medicine again, where they love to ask about hypothermia. You can see the picture of Jack and Rose in the end scene of Titanic, where Jack dies because of hypothermia, because of the freezing water of the Atlantic Ocean. So what is the current cutoff temperature for hypothermia? Well, it's going to be cold temperature less than 35 degrees Celsius. And usually hypothermia is artificially classified into primary hypothermia, which would be like a previously healthy individual like Jack in Titanic movie, and then he had to jump in water because the ship was hit by an iceberg, and he had to save life of Rose, so he decided not to climb onto the plank so that she can live, and he died because of accidental hypothermia. And if previously, if he had consumed alcohol, if he had consumed any medications, then you are aware that alcohol, antidepressants, antipsychotics, they tend to increase the chances of death, because anyway sedation part would come in, the altered mentation will set in relatively early, and alcohol anyways is going to cause vasodilation. That vasodilation will promote the heat loss from the body. So consumption of alcohol, consumption of antidepressants and antipsychotics are like risk factors which are gonna accentuate the chances of a person dying because of hypothermia. The alcohol part, I'll say once again, though troops again might be drinking brandy, they might be drinking alcohol or vodka, like Russians, they are fighting in Ukraine and temperature is -30, -40. So they'll be drinking vodka. That will depress their CNS and will bring in altered mentation much more earlier due to hypothermia. Plus, alcohol causes that flushing. It causes vasodilation. So the guy who's drunk and has consumed a lot of vodka before actually going into the battle has higher chances of dying, primarily because there would be more heat loss from his body. And the Russian winter is anyway unforgiving. So if you're an FMG listening to me, I think you can relate to this better. I mean, in the Siberia and the towns around that, the temperature is going to be killing -30, -40 degrees. Inside is obviously fine, but then outside is really, really bad. So consumption of alcohol and these drugs tend to accentuate the hypothermia related mortality. Then what is secondary hypothermia? Secondary hypothermia could be due to systemic disorders. By systemic disorders, I mean it could be sepsis. By secondary systemic disorder, I mean it could be myxedema coma. If you go to the endocrine component, I've described hypothyroidism. Towards the end of hypothyroidism, I described a topic by the name of myxedema coma, where the thyroid hormone production is almost decreased to zero. And thyroid hormones are responsible for calorie genesis. They're responsible for heat production in the body. So if the thyroid production level will decrease, person will again die due to hypothermia. And that would be a systemic disorder, which would be called as secondary hypothermia. Now for mild hypothermia, the cutoffs are like 32 to 35 degrees Celsius, and anything which is less than 32 will cause altered mentation. This person will not be able to, in fact, you might be getting very peculiar reactions, like this person might start taking off his clothes. That would be paradoxical undressing. Even in forensic medicine, you would have read that word, paradoxical undressing. So poikilothermia basically is cut off at less than 32 degrees Celsius, and this is when the altered mentation will start manifesting. And at severe hypothermia, that is less than 28 degrees Celsius, mostly person will be dying because the heart will become gradually slow, and sometimes there can be ventricular fibrillation as well. As I explained and would be reminding you from the forensic perspective, this is itself a one-liner MCQ, so I think this was not a big deal to tell you. Paradoxical undressing is seen in mountaineers before they actually die high up at Mount Everest. They'll start taking off their insulated jacket, which is going to prevent them from the cold, because hypothermia, as I said, contributes to disorientation. If luckily they're rescued and are brought down to the base camp, if you do ECG in a person of hypothermia, then even in the cardiology section, I've taught you there would be a peculiar wave present that would be called as J wave, which would also be called as Osborn wave. And this is usually at the end of the S wave. As a result of it, might be read by the automated ECG machine as a ST segment elevation. I repeat that again, because the J wave is going to be present. I've shown a deliberately prolonged PR interval. The J wave might be deliberately may be read by the ECG machine, the automated machine, as a ST elevation. That's because it is present right at where the ST segment would be starting. Then he can also ask you regarding where would you like to place the probe to check out the core temperature. And one of the preferred sites for checking out the core temperature would be the lower part of the esophagus, and there he can put up a numerical based question that where exactly in the esophagus per se. So your technical answer would be that the probe to check out the temperature would be placed about 24 centimeter below the larynx. At this, I get a lot of queries. Sir, length of esophagus is 25 centimeter. You're saying 24 centimeter. I'm saying 24 centimeter, not the entire length of the esophagus. I'm saying in the lower one third of the esophagus, that's okay. But 24 centimeter, I'm calculating from the larynx and not from the start of the esophagus. Instead of the lower esophagus, we can also be putting the probe in the rectum as well. And for rectum, he says that what should be the depth of insertion? Then the depth of insertion of the probe should be at least 15 centimeter. And also take care that the probe should be touching the rectal wall. It should not be touching the cold feces. I repeat again, it should be depth, and then it should be touching the wall of the rectum, because we want to check the temperature of the body. We don't want to check the temperature of the fecal matter. So the probe should not bury into the fecal matter or should not be touching the cold fecal matter, which would anyway be frozen by this point of time. The next concept to be remembered is that if he says that this soldier at high altitude at Siachen Glacier has suffered from hypothermia and is having ventricular fibrillation, would you first like to rewarm the body of the patient and then give a DC shock, or would you like to first give a DC shock? Then he says that if ventricular fibrillation is detected, then we can give the first DC shock right away. But then you are aware from advanced cardiac life support protocol that have said total of 3 DC shocks have to be given sequentially in any patient of ventricular fibrillation. He says that the next DC shock should be deferred. Now, this is important from the exam perspective because traditionally, as I've explained, we are supposed to give 3 sequential DC shocks to anybody in ventricular fibrillation. But if there is a hypothermia present, then the next DC shock should be deferred. What we should do is next attempt rewarming of the body of the patient. I'll also explain the strategies for rewarming. And he says that rewarm the body of the temperature or rewarm the body temperature of this patient by about 1 to 3 or 2 degrees Celsius above whatever was the initial baseline value. Suppose baseline value was 28, 29, whatever. I would like to increase it from 28 to 30 so that I can attempt a second DC shock. I mean, the responsiveness to DC shock will improve with increasing the body temperature, and this data that I've said is valid for the second DC shock. The first DC shock is anyway to be given. For the next one, wait. First, increase body temperature by 1 to 2 degrees and then deliver DC shock to improve the responsiveness to electroshock. Let us now focus on the rewarming approaches that we have. Like for example, Jack jumped into the freezing water of the Atlantic Ocean. He was able to recognize Rose. He was able to talk to Rose. So because his blood pressure was at that point of time stable and he was in his clear sensorium, that means that we have to go ahead with passive external rewarming. But suppose Jack lost consciousness, if there was a cardiovascular instability, if the body temperature went less than 32 degrees Celsius, then we would have to go ahead with active rewarming. So when are you going to answer passive rewarming in the exam? If the person is in his senses, if the person goes into altered sensorium with crashing of BP, then it is active rewarming to be answered. So then he will ask us that what will be the rate of rewarming, that is ROR. Then the ROR will be 0.5 to 2 degrees Celsius per hour. I mean, traditionally ROR is rate of return in investment terms. But for doctors, it is rate of rewarming, that would be 0.5 to 2 degrees Celsius per hour. And this is to be followed, the passive rewarming, in a person who is having a normal sensorium at this particular point of time, or at least is able to rescue, is able to identify himself to the emergency crew. He can at least tell his name to the emergency crew. So we want to go ahead with passive external rewarming. And then another important thing which I want to tell you is that lots of time, non-medical people, they will start applying heat to the hands and the feet of the person. If you apply heat to the hands and the feet of the person, it will cause a cutaneous vasodilation, and that cutaneous vasodilation will cause more loss of heat from the body that can rather cause worsening of the condition. So you have to apply the heat to the trunk. Don't apply heat. I repeat that again. Don't try to, when you rub the hands and rub the feet of the person, it will obviously give comfort. But if you're applying heat to, I'm not saying don't rub the hands and the feet. I'm saying if you apply heat to the soles, if you apply heat to the hands of this person using, let me say, electric blanket for say, or warm or hot water bottle, and is applied to the extremities, it will warm the extremities, that's okay. But the cutaneous vasodilation that ensures will cause worsening of the condition of this patient, which is technically called as after drop. After drop, as the name suggests, is subsequent decrease in body temperature, though initially the palms and the soles will become, the temperature will increase, but they are going to cause further loss of heat from the body. Now, let's say Jack fell down and into the Atlantic Ocean. He was unconscious. He was not able to identify himself to the emergency rescuers. In those circumstances, what are you going to do? Active rewarming. So as I've explained to you, the meaning of the word poikilothermia is cold temperature less than 32, and that is the time when usually altered mentation or disorientation would be setting in. Apart from this, as I said, if the BP begins to crash, if the pulses are not palpable, most of the time at this point of time, ventricular fibrillation would have initiated. That is why I'm saying the word cardiovascular instability. So the first DC shock would be given, but then how are we going to increase the body temperature? We're going to increase the body temperature by doing the following aspects. One approach is using forced air heating blanket or a blanket that uses circulating hot water. please remember, do not apply electric blankets. Lots of time electric blankets are also available. Electric blankets are not recommended. The reason for that is again that electric blankets can cause rather burning of the skin. They can actually, the peripheral skin, the extremities of the body and the peripheral part of the body is anyway having extreme vasoconstriction, and electric blankets can contribute to burns as well. So he says that we'll be using blankets that use hot air being blown into them or circulating hot water. Then we can give heated humidified oxygen. This heated humidified oxygen can be delivered via mask or it can be delivered via endotracheal tube. You see, person will be losing heat via the respiratory system also. So if you provide oxygen, it will not only take care of the cerebral edema and the pulmonary edema component that is present, which is again because of hypoxia, but the heat which is delivered by oxygen will warm the airways, it will relax the airways, and at the same time it will reduce the insensible losses of heat from the body via the respiratory system. When you have to give warm IV fluids to a person, how do you give warm saline to a patient? You're not going to ask the nurse to microwave the bottle of saline. You are going to use what is technically called as an inline countercurrent heat exchanger. Countercurrent mechanism simply implies that the heat would be delivered, like in kidney we have a countercurrent system. So fluid is going in the body of the patient, but there is a parallel system, circulating system that is delivering heat to the saline, by which you can increase the temperature of saline to in the range of about 40 to 42 degrees Celsius and not higher than that, because that can cause hemolysis as well. But warm saline, if heated to a temperature of 40 to 42 degrees Celsius using an inline countercurrent heat exchanger, would go a long way to warm the body of a person. In case the body is totally frozen, we can do thoracostomy, we can put in chest tubes, and we can do a closed thoracic lavage again with warm saline. The main message is that this is mainly, point number 4 is mainly to be used in those circumstances where the body is totally frozen. That's where closed thoracic lavage, because it will be delivering heat directly to the heart. And if you deliver heat to the heart, then ventricular fibrillation will also stop, cardiac conduction will also improve, and the peripheral circulation will gradually start improving. Then we can also do peritoneal lavage, because peritoneal cavity has big surface area, no? So peritoneal cavity, if you send in warm saline through a peritoneal dialysis catheter, then you can again increase body temperature. And then we have a couple of extracorporeal rewarming techniques also, which most of the time may not be available, but because they're given in Harrison, we need to know regarding the rate of rewarming. We can use hemodialysis, then hemodialysis is available in our country. I'm saying at a place where, like at Siachen Glacier, or let me say immediately on descent from a high altitude area, lots of time dialysis center may not be available. So if it is available, the rate of rewarming would be in the range of about 3 degrees Celsius. So continuous venovenous rewarming can increase the body temperature by about 2 to 3 degrees, then hemodialysis by about 3 to 4 degrees. But if you are using cardiopulmonary bypass, in fact that can be an MCQ, that which of the following extracorporeal blood rewarming strategies will be having the highest rate of rewarming, then answer would be cardiopulmonary bypass. To finish this topic towards the end, I would like to mention, though this would be discussed by the surgeon also, this was asked in FMG exam, that if there is a frostbite in a soldier, then the frozen tissue immersion should be in circulating water. What is the temperature that is used? And the options were 37 to 40, 40 to 42. So some books are saying 40 to 42 also, but current edition of Harrison, I mentioned the page number also, Harrison 21st, this page number 3634 categorically states that frozen tissue immersion in circulating water should be done at 37 to 40 degrees Celsius. So these are the details for this topic. I think especially if you're into adventure or if you like trekking, then you would have found this even much more interesting. In a sense that, I've tried to deliver it from a practical standpoint of view, but if you are into, trekking, then this would come in handy for you, especially as, as a doctor, if you are the only doctor in the trekking team, then this information would come in handy to provide medical rescue and medical care for those people who are with you. So thank you so much. Keep hammering, guys. Keep the pressure on, and you will do great in your careers.